Our chapter discusses healthcare and the poor. The evolution of healthcare for the poor in America has been a complex process that reflects changes in the economy, changing values in the country, and a better understanding of how health affects the ability to work. 61% of the non-elderly insured in the U.S. have employer-sponsored health insurance. Another 5% have insurance they buy themselves in the individual insurance market. 13% are covered by Medicaid, and 18% have no insurance coverage. Often, those without any insurance coverage are those that are in poverty. There have been many different policies and programs that have attempted to solve the problem of the uninsured poor. Initially, the United States had no medical care assistance for those in poverty. Any kind of assistance offered to those in need was done by civic or religious groups. This sowed the seeds for later policies where states had the primary responsibility for healthcare programs that were implemented. After World War II, private health insurance became much more common in the U.S. Insurance companies recognized that if insurance was provided through the employer, the problem of adverse selection was not an issue due to the large pool of workers buying into the insurance plan. Health insurance provided by employers was also tax exempt, unlike wages, which was a further incentive for employees to purchase it. Since health insurance was now primarily offered through employers, those without it were more likely to be in poverty. In 1965, Medicare and Medicaid were created in an attempt to help combat this issue. Medicare provided health insurance for those 65 and older, as well as disabled workers. Medicare is available for all elderly and disabled people who contributed to the payroll taxes used to fund the program. Medicaid was created for those in poverty, such as children and disabled adults. It is a federal-state program that has eligibility requirements for those who wish to use it. It is financed through a system by which each dollar of state spending is matched by dollars of federal spending. States with lower income per capita receive more of these federal dollars than those with higher income per capita. Between 1984 and 1990, Medicaid eligibility requirements were expanded. States were required to cover all pregnant women, infants, and children under 6 that had incomes below 133% of the federal poverty level. The result of the expansions during the time was that by 2005, almost 50 million people were covered by Medicaid for at least part of the year. In the mid-90s, however, Medicaid spending began to slow, both because the recession was over and new legislation regarding states providing matching funds began to take effect. 1996 brought in the Personal Responsibility and Work Opportunity Act, a welfare reform initiative that caused a sharp decline in the number of Medicaid recipients.
After Medicaid, the next large-scale effort to improve access to health care for the poor and near poor was the State Children's Health Insurance Program, which was passed in 1997. This program allows states to expand health insurance coverage to children 18 years or younger whose families earn too much for the state's Medicaid eligibility, but not enough to afford private coverage. This is a block grant program, which means that there is an annual amount of the federal money that is allocated to each state depending on the number of uninsured children with incomes 200, now 300% below the poverty level. This is different than Medicaid, which is an entitlement program for all eligible children. The effects of this program on poor and near poor children's insurance coverage was incredible. In 2008, the SCHIP covered about 7 million children in the U.S. for some portion of the year. Between 2000 and 2006, there was an increase of uninsured people in the workforce. This was due to less firms offering employee-sponsored insurance. The highlighted area of Table 12.2 shows that 55% of the non-elderly and almost one-third of all non-elderly people that had incomes below 200% of the poverty level were uninsured in 2007. Because of this, a few states created insurance programs in order to encourage low-income people not eligible for Medicaid to buy private health insurance with state subsidies. The chapter goes in depth with 3 of these programs. The first one is New York State's Healthy New York, which required all health maintenance organizations to participate in. The premiums were community rated, which means that it is the same for everyone in the same health maintenance organization, regardless of age or health status. But the premiums available are low because the state had made a novel reinsurance program, which essentially reduces the possibility of adverse selection. Next is Massachusetts Commonwealth Care, in which 2/3 of the people enrolled did not have to pay premiums. This program made health insurance affordable to low-income people not eligible for Medicaid, but not for those whose employers offer insurance and the workers may say is unaffordable. A problem with this program was that there were not enough state funds. Finally, there is Wisconsin's Badger Care Plus. This program is for all children with no access to health insurance, regardless of income. Self-employed parents, pregnant women with annual incomes up to 300% of the poverty level, and farmers. The eligible people are subsidized on a sliding scale, which means that the low-income families can enroll their children for free, while other families earning more than 300% of the poverty level needs to pay a set amount. Since 1970, Medicaid enrollees increased from 14.5 million to 49.8 million. Within that time, Medicaid and SCHIP spending more than doubled. There have been efforts to control this spending on a federal and state level. On a federal level, the Bush administration issued 2 directives in 2007. The first required states to cover 95% of all SCHIP eligible children with incomes below 200% of the poverty level before they were allowed to use federal SCHIP funds for children with incomes above 250% of the poverty level. The second restricted states' ability to expand their Medicaid income eligibility ceilings and transfer children covered by the SCHIP program to Medicaid. This was a reinforcement for discrepancies across the states in coverage of children. On a state level, there were 2 initiatives. The first was raising premiums and copayments, and the second was reductions in payments to providers.
The author mentions 4 major concerns about how public health insurance programs may fail to meet the needs of people with low income. The first has to do with the quality of care that is given to the elderly and disabled people. Recipients of Medicaid that are elderly and disabled account for around 70% of all Medicaid spending, although they are only 28% of the people who are enrolled. One of the ways that policymakers are trying to lower the cost of public health insurance is by restricting the supply of nursing home beds and also restricting access to long-term care providers. Studies show that there are many inconsistencies from state to state in Medicaid spending on long-term care services, which causes concern about the quality of care that is being given to these recipients. Efforts to improve the quality of health care for the elderly and disabled are increasing, while at the same time efforts to reduce spending are increasing as well. Policymakers will have to find the right trade-off between the two. Another concern with public health insurance programs is with people with low income who are being left out of Medicaid. One reason for this is because of the categorical eligibility requirements. Many uninsured poor people who are not eligible for Medicaid because they do not belong to a certain category of people who are eligible, such as pregnant women, children, and the elderly. Table 12.3 shows that between 41 and 52% of poor adults ages 19 to 54 were uninsured, as were 31% of adults age 55 to 64. The fraction of adults with incomes between 100 and 149% of the poverty level are similar. Many low-wage workers work for firms that do not offer employer group health insurance. People who have higher incomes are much more likely to have private insurance through their work, as is shown in the table. Less than 50% of people who make below 200% of the poverty level have private insurance coverage. Small firms are much less likely to provide their workers with health coverage, and many low-income people tend to work for these small firms. There has also been a decline overall in the companies that provide private insurance to their workers. Also, workers receiving a low wage may turn down the opportunity for ESI insurance because they cannot afford to pay the premium. Immigrants who are legal residents but not yet citizens account for a large number of uninsured people in the United States. In 2007, between 55 and 70% of immigrants who were not yet citizens did not have health insurance. Many of these people have low wage levels along with low levels of education. The 1996 welfare reform banned non-citizen immigrants from being eligible for Medicaid unless they had lived in the United States for a minimum of 5 years. However, in 2009, this law has changed to allow children who met the wage requirements to be eligible for Medicaid. Policymakers believe that in doing so, it would prevent costly problems in the future. For example, an immigrant child who does not receive health care may cause him or her to do poorly in school, which would decrease the chances of them earning higher wages in the future. Another group that is left out of Medicaid are people with mental health and substance abuse problems. Poor people who are able to work at least part-time are not eligible for Medicaid and cannot claim disability status. Also, Medicaid does not usually cover people who struggle with substance abuse. The last concern that the author mentions is efforts to increase the enrollment and re-enrollment of eligible people. One debate is whether creating more public insurance programs or building more health centers and clinics in poor areas would be the most beneficial. Another issue is that many people who are eligible for these public health care programs just don't apply for them. In 2002, more than 25% of children who were eligible were not enrolled. There are two kinds of inequities in the public health insurance system. Uninsured people in one state may have the same income as someone in another state, however, it is not likely that their coverage will be the same. The second inequity that the author talks about occurs within states. If a person has access to an ESI program, they are not eligible for Medicaid. However, this person might have the same income as someone else who would be eligible for the program. Another thing that doesn't seem fair is that income levels that make a person eligible are based on a state's ability to fund these programs. In order to receive federal matching dollars, the state must put its own funds, and some may choose to spend less than other states. The Economic Stimulus Bill of 2009 provides $87 billion over 2 years to help states fund public health insurance programs. Over the past 40 years, spending on these programs has been increasing due to an increase in the number of people enrolling, but also due to rising healthcare costs. The author says that growth in Medicaid spending is not likely to stop unless the healthcare system also changes. 20% of the U.S. population is covered by Medicaid, and 5% of children are covered by CHIP. Medicaid plays a very important role in providing health care coverage to the disabled, elderly, and pregnant women whose health care costs are likely to be high. Medicaid also keeps premiums lower for private insurance recipients because Medicaid insures many people that are high risk. The author concludes by saying that a national system of healthcare financing that includes both premiums and taxes could ensure a progressive payment system that subsidizes low-income people. Further, a national system would reduce the expensive for administrative procedures that are in place now to verify a person's eligibility for Medicaid or SCHIP and that have discouraged eligible people from enrolling in both programs.